Everybody, thank you very much for tuning in. So I'm going to talk about stillbirth today. I'm going to go through a bit of background in terms of stats and some common risk factors, and then I'm going to talk about the new Safer Baby bundle in terms of interventions and the resources and principles available for investigation and support of families both after the death and in a subsequent pregnancy. So it's a very large global problem, stillbirth. So in the world each year, there's about 2.6 million stillbirths. So clearly we are at the much lesser end in terms of the global burden. But this number is the same as if all the babies born in Western Europe in 1 year had died. So it is a very large problem, but until really the last kind of decade, it has been very sort of understudied and underreported. And it really is the tip of a global iceberg of issues around newborn health that begin with the babies that don't survive, but also is overtaken by babies that are born early. And one of the reasons that this has been such a large problem but so hidden is that stillbirths as a field or as a code, as an outcome, were not routinely reported in other global health metrics. So national surveys, routine reporting to the WHO, the Millennium Development Goals, it didn't come up as a target in any of those things. And this study from 2016 looked at major maternal and child health policies across the world and looked for certain words. And you can see the arrows there point to the word stillbirth. So very underrepresented in global policy. And one of the quotes around that was in that Lancet series here from Joy Lawn is that almost no burden that affects families is so large yet so invisible in society and on that global health agenda. So what are the numbers here in Australia? So just over 2,000 stillbirths happen in Australia every year. That corresponds to around 6 babies a day, which is around 1 in 150 women beyond 20 weeks of pregnancy. So 1 in 150 beyond 20 weeks will not take their baby home. And not all of these are inevitable. In fact, only around 1 in 5 are due to congenital anomaly. And we think from the best data available that around 20 to 30% might be preventable. This is the latest report from the AIHW, that all these reports are always a couple, 2 to 3 years kind of out of date in terms of data collection and publication. So this is looking at data from 2015 and 2016. And this data is looking at a summary over the last sort of 20 years. But whichever source you look at, there is a sort of fairly static graph in terms of perinatal deaths. Stillbirths are about double the number of neonatal deaths, but you can see there is a gap there and not much change in that rate for really some time. Oh, somehow this is supposed to show you the numbers of stillbirths and neonatal deaths, and it hasn't come up. And this is to look at causes. So when you get to see this, I think Lauren will send this around afterwards. Hopefully the picture will come up. This is really to show, again, from that report, the causes of perinatal deaths, and the most common causes of stillbirths are still in the unexplained group. That still forms a large proportion of stillbirths. And this is just coming back to that. It's around 20% of Australian stillbirths are unexplained, and sometimes that is despite adequate investigation. Sometimes it's because there has been inadequate investigation, and it's more common for a stillbirth to be unexplained near term. So you can see this graph looking at this data that covers 20 years in this report from 2016. As you get to 37 weeks and above, around half of those stillbirths are unexplained. And we know from audit data, both here in Australia and in other parts of the world, that less investigation means more stillbirths are unexplained. So this is some audit data from some time ago now from RPA, just showing that if you do follow guidelines and appropriate investigation, the unexplained rate can be around 13%, as opposed to that sort of third. In terms of risk factors for stillbirth, and we're going to go through some of these, but across the world, the risk factors for stillbirth do show some potential for prevention. So some of these are in the NCD area, some of them are around the length of a pregnancy, and some of them are around infection, and you can hear about infection later tonight from Professor Rawlinson. And some of those are about things that we can't change in a pregnancy, but we could potentially change as a society in terms of maternal age. So maternal age, smoking and maternal obesity are the three strongest risk factors for stillbirth in high-income countries. That was shown in the Lancet series in 2011, and it has not changed. So these are the three most common risk factors in high-income countries. And I'm just going to go through each of these in a little bit more detail. So this is some gestational specific data from New South Wales, looking at the risk of stillbirth per gestational age week per undelivered pregnancy. And we know that for all women, the risk of stillbirth increases beyond term, and that's the reason that we have monitoring post-term and behind the recommendations for considering induction of labour at 40+10. But you can see there in the red line that for women who are 40 or above, that risk pattern is identical, but it increases around 1 to 2 weeks earlier than for women who are not 40 or above. Particularly important for women in their first pregnancy. So if somebody is in another pregnancy and they're above 40, their risks of stillbirth are still very low. And even for nulliparous women who are 40 or above, their risks are also still low. You can see there 4 per 1,000 undelivered pregnancies. However, that is about double what it would be if they were not in that age group. And that's certainly a risk that they might not take for other things, for example, risk of aneuploidy at screening. So there are some guidelines around induction of labour in older women, and there's a guideline been out for some time in the UK. In Australia, there is not a national guidance about this, but it is covered in the pregnancy care guidelines and to be discussed on a case-by-case basis. I know at RPA we have a policy around induction of women at 40 or above, and so do the Royal Women's, and I guess those might be the two sites that many people here might be caring for women delivering in. We do know from RCT data that if you actually randomise people to planned birth versus expectant management, so planned birth meaning induction, if they're 35 years or above, there is actually no difference in adverse outcomes, and there was no difference in caesarean section. So this study was not powered to look at stillbirth, but really it is valuable data to show that if people who are of older age choose to have an induction, it appears to be relatively safe from other adverse outcome perspective. And some countries have offered, in terms of national perspective, consistent policy in terms of offering induction from 40 weeks for older women. And you can see in Denmark, they have reduced their stillbirth rate over time with that sort of national policy, but it has also impacted on slightly earlier delivery, so from 37 weeks, and I'll come back to that a little bit later. Smoking is another modifiable risk factor, and 1 in 10 women smoke during pregnancy currently, but it is very disparate in terms of the group, so much more common in remote areas, Indigenous and younger women. So there is wide variation in smoking cessation strategies and what is offered, despite some evidence of benefit. And when we talk about the bundle, I will come back to this. Maternal obesity is a very important risk factor, and as a nation, every second woman who enters pregnancy currently is BMI of 25 or above. There is a dose response rate in terms of gestational specific stillbirth with rates of obesity. We have some really nice data here from the Swedish Birth Registry showing that it's an important time between pregnancies to modify weight and reduce the risk of stillbirth. So you can see here that BMI changes of more than 2 between pregnancies result in a significant risk of stillbirth in a future pregnancy. Now, the important thing about this data, it's not trial data, it's birth registry data, but it does show that for women who lose weight between pregnancies, they actually reduce their rate of perinatal mortality. So quite useful data from Sweden. This is some data from Sydney LHD looking at perinatal outcomes and obesity over time. And obesity was investigated in this local cohort because when you look at state data, that field unfortunately has not been there for a very long time and has only come back onto the data set very recently. So you can only really get this longitudinal data from local sources. So they looked at just under 50,000 women in their first pregnancy. Again, there's that dose response risk over time with increasing problems with weight. And you can see here that the proportions of adverse outcomes as the rates of overweight and obesity have increased, they have also increased over time. And you can see there stillbirth around 7% for a population attributable risk. Ethnicity in terms of country of birth is a recently recognised risk factor in Australia for stillbirth, particularly antepartum stillbirth. And it seems to mainly be an issue for women from South Asia. So not Southeast Asia, but South Asia. So Nepal, Bangladesh, India, Sri Lanka. That was data from New South Wales, very similar data from Victoria. A sort of 1.5 times the risk of stillbirth for women who are born in South Asia. Some of that may be related to higher prevalence of growth restriction, and this again is looking at that 20-year report and how many babies seem to be affected by growth restriction when we look at the cause of death. And you can see in the area highlighted there that for term babies, undetected fetal growth restriction is particularly important. And we don't have at present a widely available good test to pick up these babies as they get further in the pregnancy. This is the data from AIHW just showing that risk of growth restriction is particularly marked when babies are very small. So it's more pronounced for the babies that are less than the 3rd centile. There are also increased risks for very large babies, more than the 97th percentile also. This is some data from a case control study that we did across 9 hospitals in Sydney some years ago that Bill was also involved in, so it's nice to be presenting together tonight. And we looked at people who had lost a baby from 32 weeks and above with 2 matched controls per each case. You can see here we looked at suspected growth restrictions. So this was regardless of whether the baby was small at birth. This was whether women had received extra scans or extra monitoring because there was clinical concerns that the baby was small. And you can see there an adjusted odds of 5.5 times. So even though we sometimes are following people because we are worried about the growth, at present, we are still not necessarily acting on that information. So what should we be doing with this information? Should we be scanning everybody in later pregnancy to look at fetal growth restriction? Well, unfortunately, the scan on its own is not really accurate enough. So this is some data from a longitudinal study called the POP study in the UK, run by Gordon Smith. And that shows that, yes, you do pick up more FGR. However, for every small baby that gets picked up on a routine scan, there are 2 false positives. So an ultrasound scan on its own without any additional biomarkers does not appear to be good enough to prevent adverse outcome. Now we're on to fetal movements. This is just to remind me that that's what we're talking about next. And this is a long-standing association in terms of risk factors for stillbirth. So unfortunately, in the late 80s, there was a very large trial about counting fetal movements that showed no difference in late stillbirth. And that trial has informed the Cochrane Review, and it has informed NICE guidelines, RCOG guidelines, etc. However, observational data keeps coming out over the following decades, showing that there is a risk of stillbirth when women perceive that the baby is not moving as much as previously. And a quality improvement study in Norway about awareness and trying to get consistent management for women who presented with decreased fetal movements has now informed a lot of guidelines, despite for some time there not being new trials, and I'll come to new trials shortly. So this Green Top guideline from the UK, 2011, was shortly after an Australian guideline that probably didn't have huge uptake. There has been New South Wales guidelines that have been taken up. There's now a national guideline that's come out through the Perinatal Society, and there has been some attempt previously to try and get some e-learning, and I'll talk about more e-learning shortly. But the largest study to try and answer the question was actually published in late 2018. So this is the AFFIRM trial. They aim to recruit just under 500,000 births. And this was really about, does a brochure and a package of care in terms of what happens when women present with reduced movements, will that prevent stillbirth? And they powered the study on a 25 to 30% reduction in stillbirth, which, considering this was for late stillbirth, was probably fairly ambitious. That's the publication of the protocol there. And then this is the study published in the Lancet. So they did see a reduction in stillbirth beyond 24 weeks, but it was non-significant, and it was a 10% reduction. They did, however, see some adverse effects that are important. So more babies in this study were admitted to the nursery. There were more preterm births. So for every stillbirth that was prevented, there were 34 more preterm babies. So clearly a concern for such a project. But there were less small babies, particularly small babies at term. So this was picking up smaller babies, preventing some deaths, but potentially with adverse outcome. And there were also some other important adverse outcomes which were resulting in these early births and admissions. So that was around planned delivery. And this really was, I guess, taken up by people saying we shouldn't really tell women about fetal movements, and encouraging an awareness might actually be harmful. And there have been various editorials written about this since. And one of the things about AFFIRM is that they had a policy of management that's quite different to what we have in New South Wales, which recommended that if nobody could be reassured by tests at 37 weeks and above, then delivery should be considered. They also struggled with the ability to implement the management protocol in terms of ultrasound scans and senior support for delivery. And hopefully that might be slightly different in Australia. They didn't have an awareness campaign. They really sort of were unable to show exactly how poor or not poor the compliance with the management protocol was. And there are two large trials that have just recently completed that are going to affect this information. So one is the Australian My Baby's Movements trial, and the other one is a Scandinavian trial called Mind Fetalness, which is about sort of empowering women in terms of perception. So I think we've got some more data to come, and at the moment this is included in the Safer Baby bundle, which I'll come to. The last risk factor they're going to talk about, which is also included in the bundle, is sleep position in late pregnancy. This was first reported in 2011 and was reported in terms of a case control study run in Auckland. And this showed that women who reported that they fell to sleep in late pregnancy, not on their left-hand side, had a higher risk of stillbirth. There were lots of controversy over this study. People thought maybe this was due to recall bias. There were some attempts to try and minimize recall bias. And there were lots of things being asked about at these interviews, not just sleep. So women wouldn't have known that this was a particular hypothesis. Pregnant women deserve better research than this. So concerns that, women have enough to feel guilty about, we shouldn't confuse them. Don't worry quite yet. challenge anybody to remember how they fell asleep. And a very sort of balanced editorial around that time. So there's now been 5 similar studies across the world looking at this issue, and they have been brought together last year in an individual patient data meta-analysis, looking at going to sleep position and the risk of late stillbirth. And there's a lot of consistency across these countries. So they're Australia, New Zealand, Africa, the US and the UK. So the adjusted odds ratio in this IPD is 2.63. You can see quite a tight confidence interval there and a very significant finding. So that has translated into advice for women. This is the advice that is available through New South Wales Health, and women coming through antenatal clinics should be receiving. This is similar across other states and territories, but New South Wales Health commissioned these flyers and resources. Similar information in New Zealand. So now I'm going to come to the Safer Baby bundle and what can we actually do in pregnancy related to these risk factors in terms of prevention. So we know from other countries that bundles of care, and so a group of interventions that together seem to make a difference, can save lives. So in both Scotland and in the UK, which I now realise is a devolved nation, so Scotland versus England and Wales, both put together a bundle about stillbirth prevention, and that included awareness of fetal growth restriction and monitoring, fetal movement awareness and a management protocol, and advice and support to stop smoking. Both of these packages resulted in a 20% reduction in stillbirth rate at 28 weeks and beyond. And so based on that, we now have support from the NHMRC and a partnership grant with New South Wales, Victoria and Queensland, and since then support from the rest of the states and territories to implement this Safer Baby bundle for Australia. And it covers these 5 elements, all of which I've spoken about a little already. So for each element, there is a best practice recommendation or consensus statement or guideline. There's some implementation tools for health services. There's a measurement strategy that is linked into routinely collected data, and there's an e-learning program for health professionals that I will show you, and some resources for women. So if you have any energy after the talk tonight, you can log on to this website. So the e-learning has been accredited by Ramscog and ACM and also ACRIM. This is all free. So you basically go into the website, you have to register, but it takes 2 seconds. And that's just so that the group know who is accessing it and from where and what their background might be. There's an introductory video, and then you are taken through these modules. Each takes around 15 to 20 minutes, and you don't need to do them all at once. So you can just log in, choose your module. You won't get a certificate of completion until you complete all of the modules. You can use it on a mobile device very easily, your phone or your iPad. There are case studies, so I know that particularly for GP learning, you always have to have case studies in there, and we've got some great GPs on the bundle education group to ensure that these are all relevant. There are posters that health services can print off related to both the movements aspect and the fetal growth restriction pathway. And I'll just go through each of these very briefly. So for each element of the bundle, there are some flyers like the one here on the left for women and for clinicians to give to women. And there are some key recommendations. So for smoking cessation, none of these things are rocket science, but it's about trying to get consistency in approach. And these 5 elements were chosen for Australia because they were 5 elements that less than 50% of surveyed services across the country did consistently every time. So it was clearly a gap in this area. So this is linked into the QUIP program, and there is an ask, advise and help model. In areas of high risk in New South Wales, there is support from the Health Department, Population Health, in terms of CO monitoring, but they are not happening just now because of the COVID pandemic. In terms of FGR, there is a pathway in terms of risk assessment that groups people into level 1 to 3 to help aid decision making, and there is teaching around exactly how to measure fundal height and to do that consistently. Awareness and management of reduced fetal movements. There is an information brochure which is included in everybody's antenatal care information, and the key thing here is for women to know that the baby's movements don't slow down at the end of pregnancy, and if they're worried they should contact their healthcare provider. That information is translated, that says 19, but I think there's now 21 languages in terms of that flyer. Not everything is translated yet. Sleeping position, this is again an awareness raising issue about going to sleep on the side, either side, from 28 weeks of pregnancy and beyond, and to remind clinicians to talk to women about that. The last element is a little bit more complicated and is still got a little bit of work to go in terms of improving both the evidence and the e-learning. But we know, as I mentioned in the background, that certain risk factors are associated with an increased risk of stillbirth, but particularly later in pregnancy. And that might benefit from a shared decision around timing of birth. So this has been linked in with a project led by Colling Institute at the University of Sydney called Every Week Counts. And this is about ensuring that although risk is discussed, the unintended consequences are also discussed, and that there is a shared decision making on planned birth. And the reason to be cautious in this area is not just the results of AFFIRM that I've already talked about, but that we are seeing a left shift in gestational age since the mid-90s across New South Wales. And much of this is planned birth for non-medical reasons. So we want to ensure that we don't make this any worse through this programme. So in terms of the Safer Baby Bundle, we have funding. We are at the stage in New South Wales where this has been launched. In New South Wales, they have taken the approach from the Department of Health to target the health districts with higher rates of stillbirth rather than to engage everybody. But these resources are freely available for everyone to use. But the chosen health departments, in terms of extra support from the Ministry of Health for quality improvement via the Clinical Excellence Commission, are Hunter New England, Western Sydney, Southwestern Sydney and Gosford, and that's because 2/3 of the deaths in New South Wales are in those areas, so that's why that's been chosen. The programme at the moment is on hold because of COVID, so there has been a launch. Those sites have done their pre-implementation surveys and questionnaires and QI learning, but they haven't done their full implementation and evaluation, and that will happen over time, and that will include surveys of both clinicians and women. So the next thing I'm going to talk about and just kind of whip through is just about investigating stillbirth and supporting families. So as shared care GPs, you won't necessarily be doing all the investigations, but it's important to know what the hospital side might be doing in terms of investigations. And of course, you will be supporting families. So in terms of recommendations for investigations in Australia, this clinical practice guideline has been out since 2008 with a revision in 2009 and then a further revision in 2019. So this is sort of a summary of the best available evidence across investigation, classification of death and supportive care for families. Its initial purpose when it was first produced was to assist parents with helping them to understand why and the cause of death, and to help clinicians and the family for future pregnancy, to try and improve audit and strategies for prevention of perinatal death. And for some time now, there has been a face-to-face skills-based workshop where each of these chapters has been translated into a small interactive group learning session. But this has been hard to get out across the country in terms of funding and educators, and even in the best circumstances, there's probably only 1 or 2 of these in each state per year, and they're limited in terms of the numbers that can attend. So as part of the Safer Baby Bundle e-learning, this improved programme has now also been put online. So if you go to that website I mentioned before, you can click also on improve, and you can go through that whole module to understand what is happening in terms of investigation and in terms of support for families. So this is what it looks like when you go in, and you basically have to go through the chapters, and there's a formative assessment with case studies again. Just very quickly to say the best test that we have is the perinatal autopsy, particularly for unexplained deaths, and that and the placental examination are really a lot better than any other test that we do in terms of yield, ability to change diagnosis or to confirm clinical findings. And for New South Wales, there's a perinatal post-mortem service with a core coordinator who should be able to communicate with families and ensure that there is some information also back to primary care in terms of whether autopsy has been performed and the findings. Auditing is really important. We have not got national audits like this in Australia, but it's a great programme in the UK called Each Baby Counts. It's funded, it's supported by RCOG, and there are reporters in different NHS trusts who collect all of the information, and you can benchmark, and that actually improves outcomes. So in New Zealand, they do that very nicely. They look at contributory factors and avoidability, and since they've started doing that in New Zealand, they have seen a reduction in perinatal death. So audit and appropriate investigation does make a difference. So just sort of lastly here, but very importantly, is those guidelines now include much more detail on respectful bereavement care for families. And this has reviewed multiple guidelines, systematic reviews, and has really boiled down to 4 key themes, but needing an organisational response, either from a health district or a hospital maternity service. And the 4 aspects are there: communication, recognition of parenthood, effective support at the right time, and shared decision making. So the advice around good communication in this guideline is all very similar to what you know about good communication anyway, but is often very poorly done for families who lose a baby. So being honest, using the right words, not using the wrong words. Don't worry, the baby wasn't normal anyway. Don't worry, you can have another pregnancy. These sorts of words are harmful and not effective. Saying that the baby has passed away is also not effective. I can't hear a heartbeat. So being honest, your baby has died. We are here to support you, is all core aspects of communication. Shared decision making. So there is lots of data around perinatal death that shows that families who don't feel included in any of the decisions, whether it's that timing of delivery or induction of the baby that has died, whether it's their ability to bath the baby, whether it's their ability to choose their follow-up, if they don't feel that that's a shared decision, then that can affect their bereavement journey. So there's some key aspects in the guideline about how to do that, how to support that. Recognition of parenthood always comes through in qualitative studies is very important. And as healthcare professionals, it's very important that we recognise that this is key. So this for us is around allowing families time, making sure that we use the name of the baby, making sure that we talk about them as a family, making sure that we give them time to make mementos if they wish. Effective support is all about doing things right the first time, and sort of really having that one chance to get things right. So people are often only in hospital for a short time if they have to birth a baby who is stillborn. And so making up for things in the weeks afterwards is not going to be effective if the support they received at the time was not good enough. So, and also allowing shared decision making, but giving some direction about what is often done, what other people do, what might be an acceptable pathway, because people are often paralysed in terms of their ability to decide what to do next. Finishing up, next pregnancy. So many women will go on to have another pregnancy, often very quickly. So more women have a pregnancy within the next 12 months who experience a loss than whether they had a live birth. And I guess that does seem obvious. There is a risk of stillbirth if there has been a previous stillbirth. And this has always been a little bit controversial, but this systematic review from 2015 does show that there is an increased risk in a subsequent pregnancy if there has been a previous stillbirth. There is obviously an increased risk for depression and anxiety, and as GPs you would probably be much more aware of this than in the hospital system. So this seems to be increased for women who have a subsequent pregnancy more close to the loss, but many people feel that they do want to have a subsequent pregnancy close to the loss. In terms of high-level evidence, in terms of what to do in the next pregnancy from a medical point of view or a mental health point of view, there is a giant gap. So Cochrane have started doing some really nice summaries of evidence with consumer stories along with their reviews. And so this is, if you are interested, if you go onto this website, Evidently Cochrane, and you search up stillbirth, it not only tells you the review, but it has quite a lot of other detail in there as well. So really, there was a real lack of data. They had 10 trials. They only looked at medical interventions. No trials have looked at, what is the best way to help parents and families in a subsequent pregnancy. We do know that future pregnancies, although they might be at risk of recurrent stillbirth, are also potentially at risk of other problems such as fetal growth restriction, and that would make sense, particularly if it was a placentally mediated stillbirth. And some centres have a particular pregnancy after loss pathway that tries to look for placental problems in a future pregnancy. So this is an example pathway from the Rainbow Clinic in Manchester in the UK, which is a model that's been replicated in a couple of places in the UK. In Australia, there is no consistent approach to pregnancy after loss at present. But this approach, looking at placental function and monitoring growth, continuity of care and support in terms of birth planning and shared decision making. In some, this is obviously small numbers, but they have shown some improvement in outcomes through that model. So in summary, stillbirth is a major public health issue, not as major in Australia as in other countries, but 1 in 150 women beyond 20 weeks of pregnancy will have a stillborn infant. There is potential for prevention and for risk factors that we already know about but we don't tackle well, and also newer risk factors that might be relatively easy to change. All deaths require adequate investigation, and the most useful thing is that post-mortem. And when we do investigate, feeding back within a clinical service is very helpful and can prevent deaths in the future. And families need a lot of support around the time of diagnosis and delivery, but also in follow-up after that and in their subsequent pregnancy. Thank you very much.
Thanks, Adrienne. It's Jane here. We do have a couple of questions.
Yep.
The first one is from a GP that has asked that they think they saw that some Eastern European women seem to be at increased risk of stillbirths too. Are you aware of that or have any idea why?
So I think it sort of depends a little bit on the size of the data set, but most of the large data sets are South Asian women. There has been some data that's shown Baltic states, but it depends a bit on the classification of countries. But the most consistent are South Asian and Middle Eastern African women. So there's some very nice data from WA, from their data linkage, looking at that risk and splitting it up between antepartum stillbirth and intrapartum stillbirth. And it seems that particularly African women are more at risk of intrapartum stillbirth, which would also fit with what's actually seen in terms of obstructed labour in African women in an African setting. So yes, I have seen that data too, but I don't think the Eastern European is consistent across the data set.
Okay, thank you. Another question that relates to the data while we're on that. It's a question about the stillbirth data from the South Asian countries. The question is that categorised by religion? Because it can be customary for some communities to, there may be more consanguinity.
Sure, so that's a very good question. So usually in the data about stillbirths and ethnicity, there in many of those data sets there is they have excluded anomalies. So in the New South Wales data, the Victorian and that WA, there aren't anomalies in there. So it's not that consanguinity is a part of that excess risk. None of those data sets take religion into account. One of the hypotheses around the risk for South Asian women is that it is twofold. One is that the average time of spontaneous labour in South Asian women seems to be slightly earlier, and also the rate of growth restriction late in pregnancy seems to be higher. So there is some thinking that in South Asian women, the placenta might run out of steam a little bit earlier than in Caucasian women, but I think that's still sort of under investigation.
Thank you. And just following on from that, another question is for women from South Asian backgrounds who've had a normal full-term delivery in the past, do they need to have an induction of labour for subsequent pregnancies before term?
So that's another really good question. So at the moment that we don't have a policy around induction of labour for South Asian women. So there are places in Australia that do have such a policy. So Monash Health in Melbourne has implemented a policy of post-term surveillance from 38 weeks instead of from 40 weeks, which is what they would do for the general population. And they have done that rather than offering everybody an induction, they're just starting that surveillance process a little bit earlier so they can potentially pick up where a placenta might be failing. But as I mentioned before, we don't have really good tests. So I'm not saying that people need to be induced before term. However, there is some data to support not leaving somebody who's South Asian born until 41 weeks. So having that conversation from 39 weeks rather than from 41 weeks. So this is not about trying to create early term birth. It's just about having that discussion alongside where the increased risk is for that population, similar to what would happen for women of advanced maternal age.
Okay, thank you. I think that that's probably the time that we have for questions. There are a couple more, Adrienne, so we will be able to keep those questions and we could forward those to you for further feedback. So thank you to people that submitted questions, but that's probably all we have time for now. So I'll hand back to Lauren, and thank you again, Adrienne.
Thanks very much.
Thank you, Adrienne. I'd now like to welcome Professor Bill Rawlinson. He's a Senior Medical Virologist and Director of Serology, Virology and OTDS Laboratories at New South Wales Health Pathology, Randwick. Please welcome Professor Rawlinson.
Hello, and thanks for the invitation. I just need to share my screen. Yep, and there we are. You can see my screen okay?
Yes, Bill, all good.
So look, thanks very much for the invitation to speak, and it's great to come after Adrienne. We've worked with her previously on stillbirth and looking at infectious causes, and it's been a great privilege. So it's great to come after her. This is my email address if people want to email me questions. And my remit for tonight is to talk with you about viral infections of pregnancy. And I was going to cover a fair few because I think it's not something we necessarily talk about a lot. And so I was going to cover general concepts initially, and then really focus particularly on cytomegalovirus, which is the most common viral cause of congenital malformation in this country. And then also on parvo B19, because we do get questions about that clinically. Rubella, because it's historically important, but in Australia it's not a major cause of congenital malformation. And then if there's time, we'll talk about Zika virus and SARS-CoV-2, the cause of COVID-19, at the end. So I'm going to talk about our work. This is our research group. We actually have a research interest in congenital infections, and particularly in congenital CMV. And so initially, a bit of an introduction. And this may be straightforward to all of you, but I just thought it was important to get a kind of basis for the general issues around transmission, and before we talk about specific viruses. Most of the viruses that I'm going to talk about are actually transmitted transplacentally, and that's because they have a viremic stage. They infect the placenta and then are transmitted across the placenta. Of course, ascending infection, particularly with herpes simplex virus during delivery, is an important cause of infection postnatally. And you do get postnatal infection associated with breast milk, and we're going to talk about that. But I think it's very important conceptually at the start to remember that infection is not the same as disease. And so just because a virus is transmitted doesn't necessarily mean that the neonate will suffer from adverse consequences. So maternal determinants of transmission of virus to the fetus. Usually the placenta is an effective barrier, although there are changes that occur and are associated, for example, with ascending infection. But it's also important that hormonal changes associated with pregnancy are sometimes associated with viral reactivation. Cytomegalovirus is a very good example of that. You do see reactivation of cytomegalovirus, a result of abbreviated CMV, in about 10 to 15% of women. And that's a perfectly normal, if you like, part of pregnancy in 1 in 6 or maybe even 1 in 5 women. Part of that is driven by hormonal effects on the genome of the virus. Viral determinants, clearly it makes sense if you have high viral loads, and we certainly know for things like HIV, hepatitis C, that if you reduce the viral load to undetectable, then the risk of transmission effectively becomes very low to negligible. It's interesting that sometimes viruses like CMV, where we find very high viral loads in some primary infections in the amniotic fluid and placenta, are not associated with illness in the fetus. So it's clearly not just a viral load issue. There are also some strain-specific effects. It does seem that some types are more likely to transmit. And for example, in CMV, which is a herpes virus, therefore it becomes latent in the body, that may be protective, but then reinfection with a different strain may be associated with transmission. And that's our working hypothesis at the moment for the occurrence of congenital CMV in women who are previously infected prior to pregnancy. And of course, some viruses modulate the host immune response, HIV, of course, through CD4, but then there are also things like CMV modulation of HLA class 1 and NK cells, which are associated with the increased risk of transmission from mother to baby. The transplacental trafficking of maternal lymphocytes and free virus are both associated with transmission from mother to baby. I've mentioned ascending infection, which we're not going to discuss in this setting, although it is important in other settings. And there are placental and in fact viral receptors which are present, which are sometimes upregulated in pregnancy, in which the viruses exploit. For example, an annexin 2, which is a receptor on trophoblasts, is used by CMV to cross the placenta. So there's clearly adaptation between the virus and humans in order to allow vertical transmission. Transplacental maternal antibody may be insufficient or ineffective, and it's important that to remember the fetus actually does have an immune response, and we can measure it in fetal blood or in cord blood, and that may be associated with protection in some cases. Large doses, as I mentioned, may not transmit, but probably parturition and transmission postnatally are related to viral dose. Lack of maternal antibody, because that fixes particularly free virus, and it may be cell-free virus, it's very important, and of course the immature immune response of the virus. The placenta is a fascinating organ which we and others study, and it is really quite amazing if you look from first trimester, second trimester and third trimester at just the changes you see, and these are associated, as you might imagine, with differences in transmission. So for example, even though transmission may be harder in the first trimester, it's often associated with more severe illness in the fetus, and you do see transmission occurring in the third trimester, that's typically more common, but again typically associated with less severe disease in the fetus. So really what I'm going to talk about are viruses that are typically transmitted transplacentally. I'm not going to talk about ascending infection, and I'm not going to talk so much about intrapartum or postnatal infection. The type of virus and the types of abnormalities you see do seem to differ. So different viruses, either at different stages of pregnancy, as I mentioned, first, second and third trimester, do cause different changes, but just the nature of the virus. So for example, something like influenza is an uncommon cause of abnormalities during pregnancy, despite the very large number. So even though we regard pregnant women as an at-risk group and hence recommend influenza vaccination very strongly, in terms of the very large number of infections that occur, you have a relatively small number, although of course when it does occur, it may cause severe illness in the mother, and in some cases sadly death, of course, but typically you don't tend to see fetal abnormalities, and this is probably because influenza is a horizontally spread infection that causes a very severe rapid illness, but it doesn't establish latency. On the other hand, something like rubella and CMV, which in the mother usually cause a fairly minimal illness, not always, but usually, don't tend to kill the fetus, but what they do is they infect the fetus, they cause a chronic infection, if you like, in utero, and by doing that you then get organ abnormalities and really embryopathy. And so there's a very strong difference between these. Of course, infection also occurs in the newborn, and that may be as a result of mother-to-child transmission, either during transmission or either during parturition or immediately after birth. This is herpes simplex virus, so this is an infection that's occurred during birth and through a woman who has infection at that time. So it's a direct spread from the mother to the baby. It's physically direct spread, and important to remember this is exactly the same virus genetically as the one we see infecting adults. This is actually an IL, so due to HSV. As I mentioned, just because you find a virus in breast milk doesn't mean that that's a contraindication to breastfeeding, and doesn't necessarily mean that the newborn will acquire disease. HIV is a classic example where detection in the breast milk is associated with newborn disease. There's a lot of discussion about, of course, the importance of breastfeeding versus the risk of transmission, and we're not going to talk about that tonight. But it's really to show you that things, for example, such as EBV are really HTLV1. We don't know so much about, but they can be transmitted. although they're not necessarily a contraindication to breastfeeding. So I'm going to talk about what congenital infections are common. These are some figures from Australia that we sort of came up with some years ago, and they're still quite current. And by far the most common congenital infection is CMV, or cytomegalovirus. HSV, as I mentioned, can be transmitted during delivery, very rarely in utero, and that's really because you have to have viremia. The incidence is really very low compared to something like CMV. And in Australia, it's estimated that there's about one congenitally CMV infected baby born each day. It's about 350 to 400. Other viruses, which are very common, enterovirus is a very common infection. It is difficult to transmit enterovirus in utero, and it's really unknown how many babies are affected each year. But despite very frequent infections, it's not thought that enterovirus is a major cause of congenital abnormality. And as I mentioned, rubella, extremely rare. In fact, it's probably much less than this now. We see about one congenital rubella syndrome infant born every 3 to 5 years. The other point is that some of these infections, such as CMV, such as hepatitis B, you often don't see much in the way of clinical effects. Parvovirus you might, but don't always. And so the relationship between maternal illness and fetal illness with viral infections is not by no means one-to-one. And that's probably part of the way that congenital infections and mother-to-child transmission, vertical transmission, have really developed. So the virus has developed alongside human evolution and evolved to spread from mother to child with minimal effects on the mother in some cases, like CMV. The other point is that when you're faced with an affected neonate, so in this case this child has jaundice and is clearly undergoing phototherapy, has hepatosplenomegaly, and is clearly in neonatal ICU. There's no real classical syndrome. I think the days when, for example, rubella was classically associated with eye changes and cataracts and myocardial changes, as well as other things such as shown here with jaundice, purpura, really have gone, and we're not seeing these clearly distinguished very severe syndromes. And so investigation is made harder, for example, in the neonate who has purpura, who may have bone marrow affected by CMV or toxoplasmosis or syphilis in some cases. And so it's quite important to keep a reasonably broad differential diagnosis early on. Eye abnormalities, less common. Things like cataracts, classically associated with rubella, but also due to things like CMV. Chorioretinitis, classically associated with CMV, with cytomegalovirus, but also due to extensive infection with herpes simplex and varicella zoster virus. But again, those children tend to be more severely affected. And microphthalmia, again, a classical presentation of CMV, 60 or 70 years ago, a classical presentation of eye signs with rubella. Orthopedic signs, much less common, particularly associated, again, classically with syphilis, but also occur with rubella toxoplasmosis. And congenital heart disease may be associated with CMV. It's not very common and infectious consequence of congenital infection. Neurological signs, sadly, are probably more prominent these days and are picked up often earlier because of things like cerebral calcification, due to things like CMV, varicella zoster, toxoplasmosis, and the classical differential is between cytomegalovirus and toxoplasmosis. Countries like Australia have much higher rates of CMV. If you look at a country like France, probably on the basis mainly of rare cooked meat, toxoplasmosis is much more common. But we see probably in Australia around about 10 to 20 cases of congenital toxoplasmosis a year. And encephalitis, I mentioned enterovirus, there are literally probably millions of enteroviral infections in Australia a year, mostly associated with a mild fever and rapid resolution. It's not numerically an important cause of encephalitis, but it certainly can cause severe illness in the neonate. Diagnosis is often quite difficult unless it's being considered, because I think, you know, with rubella vaccination, we do think that a lot of these problems are resolved, and so things like congenital CMV need to be considered, because maternal illness may be occurring in only about half of mothers who have primary disease, which is associated with transmission in about 1 in 3 cases to the fetus. So although maternal illness may be useful, and maternal exposure in places like daycare, for example, to enterovirus to congenital to CMV, it may often be that these are minimally or largely asymptomatic. Risk factors like sexually transmitted infections, women who have no antenatal care, so a sort of high risk profile, is more likely to be associated with congenital infection and should be considered. Neonatal presentation, as I mentioned, is often quite non-specific in the sense that an abnormality is present, but it's not a clear syndrome. Things like prematurity are associated with many infections that I've mentioned. Microcephaly, and we'll talk a little bit about Zika virus, but can be associated with things like congenital CMV and HSV. Unexplained neurological disease, unexplained eye findings or jaundice really should prompt consideration of investigation for these viruses, because it's relatively straightforward. We now have tests for these, and we have fairly straightforward molecular tests. As somebody who runs a reference laboratory, you know, my request is as many specimens as possible, but really the important ones to think about are the placenta, and Adrienne talked about, you know, histological examination of placenta. Of course, it can also be interrogated, if you like, using molecular testing, so we can do PCR and things on the placenta to narrow down, or to really start to think about what the infection may be. Urine's important, particularly for things like CMV. It's often very difficult to get blood clearly from a neonate, but in some cases it's useful, for example, to think, well, if you can't get it from the neonate, it may be easier to get from the mother. For example, if a mother is CMV seronegative, then she's not passed it on to her infant. And things like neurological disease where it's indicated. But again, these are difficult to obtain. We typically now use nucleic acid testing, as I'm sure you're all aware, and essentially there are now multiplex PCRs available which we can use for all of these infections. We don't use immunofluorescence or virus culture except in a reference laboratory like ours, or in research. We still do use serology, even though it's a very old-fashioned technique, and it is useful where the acute infection can't be diagnosed on the basis of NAT, but an organism is suspected, and we can do specific serology, and that's clearly for things like syphilis and toxoplasma and cytomegalovirus. It can be quite useful, and electron microscopy really is only in a research or reference setting. We now do a lot of things multiplex, so PCR is really a closed test. You only get one result, but we put these together, as I'm sure you're all aware, and increasingly where we find an organism, we can, a viral or in fact a bacterial or other organism, we can genotype, and that's really mainly of interest in looking at transmission. It's not particularly a diagnostic issue. The other thing we do is go back and do testing on the neonatal blood screening card, the Guthrie's card. In New South Wales, these are held lifelong. However, if you look at the positivity rate, the sensitivity for something like congenital CMV, we used to think this was a very good idea, because it would make sense that if they had a congenital infection, it would be present in their blood. And then when the baby's born, you could take the Guthrie's card and test it. But unfortunately, probably as a result of inadequacy of our testing, the sensitivity is quite low, although the specificity is very good. I think in going forward, it's likely we can improve upon this sensitivity, and it's likely we will be increasingly using neonatal blood screening cards. So now I'll talk about some specific infections. Cytomegalovirus, as I mentioned. the most common cause of congenital malformation in this country, and in fact in developed countries. This is an email from a woman who I've asked, and she said I could judge people, but really she'd never heard of CMV. It first arose when she had an abnormality shown on fetal ultrasound. She then went on to have testing and amniocentesis, and in fact had a termination for a severely affected fetus. And this is a story that most of us who have congenital infections clinics hear all the time, that mothers don't know about congenital CMV, they're not told about it. There are now a lot of resources. We've done studies with Antonia Shand at the Royal Hospital for Women and others, and we've shown that really only about 1 in 20 women have actually ever heard of congenital CMV. And this is despite the fact that these are US figures, but they're exactly the same in Australia. This is a paper we published with some people from the CDC, Mike Cannon. But basically abnormalities or disabilities due to congenital CMV are far more common than all other abnormalities, except cerebral palsy. And there's been some good work on cerebral palsy done by Haley Smith-Sheedy and others, which have shown that a proportion of cerebral palsy is due to congenital CMV. And in fact, a significant proportion, probably about 5 to 10% of hearing disorders, of hearing loss, is also due to congenital CMV. So despite it being frequent, despite it being important and severe, congenital CMV is not recognised by most parents, and also by a lot of clinicians. And these are some data from a paper by Dahl et al. From Melbourne. And this is looking at a hearing clinic, and no diagnosis for hearing loss made in about 40%, CMV in about 8%. And we published some data from Sydney a couple of years ago, and our figure was, I think, 9%, so very similar to that. So a significant cause of hearing loss, and the most common viral cause of congenital malformation in Australia. CMV is spread vertically. Rarely is it spread at the time of birth, and in utero infection occurs in probably about 1% of the population. And that means about 350 babies are born each year with congenital CMV and disease. That's about an eighth, so about 2,200 babies actually are infected. And that's on the basis that if you have primary infection or first infection, which has about a 1 in 3 placental transmission rate, so about a third of those who transmit are symptomatic at birth, and another 20% or so have long-term sequelae which are picked up subsequently. And these are just the figures for Australia. If there's about 300,000 live births, if you use this the primary infection rate of 0.64, there's about 2,000 infections. About a third of those infected, and about a half of those are symptomatic at birth. So you come up between those who have infection at birth and those who develop infection later, with about 350 babies born each year with disease due to congenital CMV. CMV is transmitted typically by very close contact, so by sexual transmission or by salivary transmission, but really by close contact rather than just sort of in a room. And as I mentioned, vertically transmitted, and probably co-evolved with humans to do this. So it has a lot of mechanisms to subvert the immune system and get it across the placenta. The effects we see in infected child, we mentioned jaundice and thrombocytopenia, hepatosplenomegaly, involvement of the bone marrow resulting in purpura and bleeding, may be asymptomatic at birth, and hence needs to be considered, and progressive sensorineural hearing losses occurred up to the age of 5 years. And in line with the work we did with Adrienne and her group some years ago, a proportion of stillborn babies are actually a result of congenital CMV infection and death in utero from CMV. The important point to make is that these are cross sections of placentae. These are the controls, and the dark bits are stained with CMV. The placenta gets infected everywhere really, and it is interesting in that placenta, which show a lot of infections such as this, are not always associated with transmission from the mother to the baby, and it's not clear why, and that's one of the research interests we and others have. But if we could solve that, why that's occurring, then clearly it would be something we could use in preventing congenital CMV. There's been a lot of discussion about screening, that is, should we screen all mothers? And in summary, just sort of to say at the start, the current recommendation, our current recommendation, is that universal maternal screening is not indicated. There are a number of features of maternal screening that CMV does match, and these are some sort of updates on the screening criteria. However, the difficulty is really around what you do with positive results and how to take that forward. And there are some therapeutics which are being developed. There is some data around the utility of intravenous immunoglobulin, for example, but because such utility is fairly minimal, it probably does reduce transmission, but only by a small amount. And currently, screening for CMV is not going to join this kind of list. So the other problem with CMV is, unlike rubella, which has had such a spectacular reduction with vaccination, has really been fantastic. There's no really good vaccine for congenital CMV. There are some that are being developed. There was a trial now 10 years ago, which was showed about a 50% vaccine efficacy, so fairly minimal. But one thing we could look at is screening of not all women and not all infants, but those with risk. And we did some analyses. This is from this paper by Mike Cannon that we participated. So these are US figures. But if you look at that, and just in summary, if you look at all infants with hearing loss, there's clearly a benefit, and there's clearly a benefit in detecting children who may have delayed hearing loss and are asymptomatic at birth, but also in detecting children with other symptoms which may not be recognised as due to congenital CMV. By screening these infants with hearing loss, you'll pick them up as well. And in essence, we came to the conclusion that screening neonates with hearing loss was a useful thing to do, and in fact, that's now done routinely in the where I work. In terms of other things like cognitive deficit, it's not as clear that screening will actually have benefits. Clearly, with hearing loss, you can do a lot of things about intervening. And you can do, as a paediatric colleague of mine said, hearing at that age is basically intelligence, whereas cognitive deficits are probably a result of neurological infection. And it's not so clear that use of antivirals in this setting is so useful. So I'm going to talk in less detail about a couple of other important infections. Parvovirus, discovered by an Australian, Yvonne Cossart, who sadly passed away a few years ago. This virus targets rapidly dividing cells, and that's why it infects the fetus and results in hydrops fetalis in severe infection, because you see loss of marrow function and basically fetal anemia. If the fetus recovers, we believe that there's no residual deficit. Again, my paediatric colleagues tell me that this is parvovirus B19, so I believe them. I prefer to do a test, but it's a fairly non-specific lacy rash, although those who've seen it a lot are very comfortable diagnosing on the basis of this in kids. The lacy rash comes after the classic facial rash, and it usually lasts for 1 to 3 weeks. Rubella, as I mentioned, really is not a problem in Australia. Congenital rubella syndrome we see a case about once every, on average, I think 4 years, and those are typically in people from unvaccinated populations. So that's where really we need to concentrate our diagnostics. Of course, if it does occur in a pregnant woman, and particularly if rubella occurs in a pregnant woman in early gestation, then the outcomes of the fetus can be disastrous. And as I mentioned, these effects are time dependent. First trimester, about a 1 in 2 chance of a defect, whereas by the third trimester, the chance of a defect is much lower. What we have seen, of course, is with rubella vaccination and with universal rubella vaccination, congenital rubella syndrome as a disease in Australia has really largely been eliminated. The disease that you see is again fairly non-specific in nature. Again, people do recognise it who've seen it routinely or seen it regularly, but those people are really becoming fewer and farther between. But it's a classical exanthem and associated with fairly straightforward virus isolation from multiple sites, but very rare. Enteroviruses, very common infection, hand, foot, and mouth. Virus is virology is fairly concrete, hand, foot, and mouth, or a combination thereof. A couple of hundred different types of enteroviruses, most of which cause a mild illness, although enterovirus 71 can cause a very severe illness. Not particularly more severe in pregnant women, but does seem to be more severe in very young infants. And this is an outbreak that occurred in predominantly northern Sydney and sort of central coast, and peaked around March about 4 years ago. And these are just the cases. They were predominantly, again, classically within clusters. And this is of an enterovirus called enterovirus 71 that I suspect all of you have heard of, which causes a much more severe neurological illness. And that's because it targets the base of the brain, particularly the medulla. And it's you get an appearance on MRI, which is very much like the appearance you see with polio. And unfortunately, there's no vaccine for enterovirus 71, but it's not particularly severe, as I mentioned, in pregnant women, but is more severe in the very young. And you can see similar disease due to other non-EV71 enteroviruses, and this is from an outbreak that was written up at Sydney Children's Hospital by Wheeling Teo, and abnormalities of MRI were quite frequent. Not all EV71 infected children and neonates have a positive lumbar puncture. And in this case, intravenous immunoglobulin was used to treat the most severely affected infants and children, and in fact, it did appear to have some benefit, so it's important to make the diagnosis. Other enteroviruses, it's really not clear how frequently there is transplacental transmission. It seems to be that infection in the third trimester or immediately after birth is more common. And as I mentioned, despite the millions of enteroviral infections that occur, it does seem that fortunately it's a really very small number of fetuses and neonates that are affected. I've certainly seen infants die in utero due to enterovirus, and also be born small and excuse me, with myocarditis, but again, very uncommon. Zika virus was very topical a couple of years ago because there was the outbreak, as you know, in Brazil, and particularly it was seen associated with neurological disease, initially with microcephaly, although it became very evident later on that microcephaly was the most severe spectrum of Zika virus neurological infection. Most cases, in fact, are asymptomatic. There was a very large outbreak in Yapen Island, northwest of Australia, and really those, the most severe outcome was that some people had reversible Guillain-Barré syndrome despite the whole island being infected, and really microcephaly was not seen as a major outcome. So there was a lot of interest in why the Brazilian outbreak and then the South American and other outbreaks were associated with microcephaly. There was a lot of discussion around whether there was a co-infection, and there's some evidence of that. There's a lot of discussion around toxins. There was less evidence for that, but there was quite clearly an association between Zika virus causing microcephaly. And these are some of the early data now from 4 years ago. There was a very large outbreak, as you're aware, particularly within parts of Brazil, and that seemed to come on very quickly, and in fact did disappear relatively quickly as the population became immune, and was particularly associated most severely with microcephaly. And the recognition of this is probably because the syndrome is so clear, although the other neurological syndromes were almost certainly occurring at the same time. They weren't recognised because they weren't so clinically obvious. There are basically two lineages. One's an African from the original description, which was in Uganda 100 years ago, and also the Asian lineage, which was seen more recently. And the vectors are present in Australia, for example, but the vectors that we see, such as this species of mosquito, Albopictus, don't seem to spread it as easily. And so, in fact, Australia saw really imported cases, but no cases acquired within the country. And this is, that's Fiji, and Yap is up here. As I say, in 2007, the entire island was infected, and yet the disease seemed to be very mild. Finally, I thought I'd talk about SARS-CoV-2. You'd have to be living on another planet not to have been inundated with discussions about severe acute respiratory syndrome due to coronavirus type 2. In terms of pregnancy and in terms of the neonate and infants, fortunately, it does not seem to be causing severe disease. Mother-to-child transmission is uncertain. Where it's been documented, it's thought that respiratory or skin contact transmission has not been ruled out. And importantly, despite a very small number of infants severely affected with pneumonia, and in a couple of cases dying, there does seem to be really infants have not had a very severe outcome, which has been very good. Breastfeeding has been published, and we have an interest in this in our research setting. In most cases, virus has not been found in breast milk. Whether it's actually transmitted is also interesting. There's been just recently a couple of symptomatic women who had breast milk that was positive. Clearly, there's always concern that it may be spread on the skin, although I think in the case of these two women, it was fairly clear that that it was not spread in that way. They were very careful. And so international guidelines recommend the continuation of breastfeeding. It's really around respiratory contact between the mother who's delivered the baby and the neonate. We're just publishing our data on Holder pasteurisation in terms of banked breast milk, but it does destroy the viability of live virus. As I mentioned, it was really very good that we don't seem to see worse outcomes with this infection in pregnant women, because with pandemic influenza in 2009, we saw very severe outcomes, and in fact, pregnant women were dying from pandemic influenza. This is some pictures from a recent paper. All papers, as you might imagine, are recent, but this is the typical ground glass appearance associated with SARS-CoV-2 with some resolution over time. So that's all I'm going to say. Just to think about screening, to think about infection, and to think about infants who are born who might be at risk, because we do have tests for all these viruses now. And thanks for your attention.
Thank you, Bill. It's Jane here, and I do have some questions. We've had quite a few come through about CMV screening, but that was prior to you talking about that in detail. So hopefully those people have had those questions answered. We do have some about COVID-19. And the first one relates to a recent study in the UK by the Royal College of Obstetricians and Gynecologists. And the question is that this study found severe cases of COVID mainly occur in the 3rd trimester. Does this translate to the Australian scene? And how does it affect the advice GPs give to pregnant women sending their children back to school?
So there's 3 questions there. So starting to the Australian scene, look, we don't know. It's just been so different between different populations. The way that the outbreak has unfolded in Australia has been so different to the UK that it's not obvious that we should translate the same data. I think that the risk to the pregnant woman, in my view, and on the basis of large numbers that have been seen and a small number of studies. So despite the very large numbers of infections, we haven't seen sort of much information about pregnancy, but it does still, in my view, appear that SARS-CoV-2 infection in pregnancy is not associated with such severe disease. And look, it is somewhat counterintuitive. Pregnancy is associated with relative immune suppression, and so you would expect viral illness to be worse, but it may well be that because pneumonia is associated with lung inflammation, then in fact immune suppression may be of some benefit in reducing the severity of the phenotype. How that relates to back to school and how infection risk relates to back to school, I don't know that I can really answer that. I think that the back to school issue is a political, social, personal, as well as a virological one, and the virological issues come last. So I don't think any of the data from the UK so far have influenced that.
Okay, thank you. A couple of GPs have asked about the torch screening and if that should be done as a part of routine antenatal tests.
Torch screening is always slightly problematic because it involves things that in Australia are relatively low risk, things like toxoplasmosis. And I prefer, in thinking as a clinician, that I think about the person before me. I think that that's why screening is difficult. It's a really good question, but in short, I think that if it's not something that we're going to do something about, then screening a large number of low-risk individuals creates a lot of difficulty. For example, around things like toxoplasma IgM positivity, whereas testing somebody, for example, as I've seen done, who has come from France or is at a higher risk in that setting, has been useful. I think that routine screening of pregnant women for those things is not of use. I think that it's useful to look at risk groups and do the testing and try and tailor it. I think torch as a concept is actually now quite out of date, and that it's better to look at individuals. I realise that that sort of puts the onus back on GPs to say, well, what are those risk groups? But I think if you look at things like origin, illness, adolescent pregnancy, and antenatal care, those kind of issues, then I think they can direct the sorts of tests you do.
Thanks, and this will probably be the last question. So with infections such as enterovirus, is there a particular time during pregnancy when exposure poses a higher risk?
I think it's third trimester for enterovirus. It's quite different to the others. I think it's more of a viremia, and it's more like influenza. It's a very severe acute infection, and it's probably the viremia and overwhelming the placenta with fetal infection which drives fetal severe illness, rather than other things like CMV, where it's the gradual disease occurring, or the embryopathy, if you like, that's occurring. So I think it's third trimester, and a pregnant woman who has a febrile illness with a rash in the third trimester, in my view, should be investigated, because it does have some implications for things like delivery and prognosis.